Hi, this is Tessa Nations, and this is my nursing assessment video for 620 at Maryville University. This is my patient, Mr. West. He is a 30-year-old male. Prior to entering the examination room, we took his vitals, we obtained his height and weight, we determined his BMI. We also had him empty his bladder, and then upon entering the examination room, I watched his gait and balance, which were all intact. So we're going to go ahead and get started with our assessment at this point. We're going to start with the face. I'm going to have you smile real big for me. Clench your teeth. Stick out your tongue. Okay, we're then going to look at the characteristics of the face. Look at the eyes and the ears and make sure they're symmetrical. I'm going to move on and palpate the scalp, noting any masses or nodules. Also look at the hair and the texture of the hair. Okay. We're going to go ahead and move down to the eyes. We're going to start by inspecting the eyes, the eyebrows, the eyelids, the eyelashes. Going to have him close his eyes and make sure that the eyelid covers the eye. Okay. We're then going to pull down the eyelids and kind of look at the conjunctiva and the sclera, make sure they're not red or inflamed or have any signs of infection. We're then going to move on and palpate the lacrimal apparatus. Tell me if there's any tenderness.
No.
Okay. After palpating that, we're going to go ahead and palpate the sinuses. So I'm going to go ahead and palpate the sinuses. Tell me if you have any pain.
No. No.
Okay. I'm then going to go ahead and look at the pupillary response. We're both going to look at the direct and consensual. So direct, and then you're going to look at the opposite eye and make sure that you have consensual. Okay. Prior to entering the examination room, we also used the Snellen chart to test his far vision, and we also had him read a newspaper for his near vision, and all of that was intact. So I'm then going to have you stare at that spot on the wall. We're going to do the cover and uncover test, which checks for cross eyes or any cross-eyed movement while trying to focus. So go ahead and cover one eye. Okay, and then cover the other eye. Okay, and I didn't note any of that with that. So I'm then going to check your cardinal fields of vision. So I would like you to follow my finger. It is not uncommon when you do the right and lateral movements to see some nystagmus, although you didn't have any. Then going to move on from the ears, the eyes to the ears. So we're going to start by inspecting the ears, the symmetry again. You're going to kind of palpate the auricle. You want to kind of do a tug test and make sure there's no tenderness before you do the otoscope exam. Any tenderness with that?
No.
Okay, we're then going to go ahead and do the whisper test. So what I'm going to do is I'm going to have you occlude one ear, and I'm going to whisper a two-syllable phrase into the opposite ear and tell me what I say. Baseball.
Baseball.
Correct.
Apple.
Good. Okay, to further assess hearing, we are now going to do the Weber and Renna test. With the Weber test, what I'm going to do is hit the tuning fork, put it on the center of your head, and you tell me if you can hear it in bilateral ears, okay? Bilateral, both ears equally? Okay. With the Renna test, what I'm going to do is, again, hit the tuning fork, put it on the mastoid bone behind your ear, tell me when you can no longer hear it, and then going to move it in front of your auditory canal, and then tell me when you can no longer hear it that way as well, okay?
No. No.
Okay. We're going to do the same thing to the other side. Air to bone conduction should be about 2 to 1, which it was. So I'm going to do the other side now.
No.
Then gonna go ahead and move on to the otoscope exam. You want to pull the pinna up and back, insert the largest speculum that would fit comfortably.
May I have your attention, please? Regular visiting hours are now over.
Seriously?
Visitor identification is required for visitors who have permission to remain on the floor. A visitor pass must be obtained at the front lobby desk from the
Sorry
security
about that.
officer. Regular visiting hours are now over.
One more time.
Visitor identification is required for visitors who have permission to remain on the floor. A visitor pass must be obtained at the front lobby desk from the security officer.
Okay, back to the otoscope exam. We're going to pull the pinna up and back, insert the speculum into the ear, examine. Going to look and make sure there's no redness or swelling. You also want to look at the tympanic membrane and make sure that it looks white and pearly, which it does. Same thing with the other side. Okay. Going to move on to the nose. We're going to look again at the symmetry of the nose. I'm going to have you occlude one side of the nose. We'll take a deep breath in. Okay, and then do the same with the other side. Didn't note any congestion. Did you note any congestion?
Nope.
Okay, make sure that the septum is midline. Want to kind of look at the turbinates and make sure that there's no redness or inflammation, any drainage, and it looks good. Okay, we're then going to move on to the mouth. So I want you to, you're going to look at the lips, have him kind of open his mouth, look at the gums, the buccal mucosa. Have him say ah. I'm going to look at the uvula, posterior pharynx, and the pillars, tonsils, although he doesn't have any. Also look at the teeth, the characteristic and the number of the teeth, what kind of condition that they're in. Okay, and then you're also going to test the gag reflex. Okay. Before we leave the face to go on to the neck, we're going to do the sensation test. So we're going to take a Q-tip as well as a safety pin, and I would like you to tell me if you feel sharp or dull. So close your eyes.
Soft. 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 Sharp. Sharp.
Okay. All right, we're now going to move on to the neck. And with the neck, we're going to inspect the neck for symmetry. You want to make sure that the trachea is midline. You're also going to palpate both the carotid pulse. One side at a time. You don't want to occlude both carotid arteries at the same time. You can also ask them to swallow and kind of feel the thyroid gland. Okay. We're also going to palpate the lymph nodes. So we're going to start with pre-auricular, go to post-auricular, occipital, tonsillar, submental, superficial cervical chain, and then posterior cervical chain, deep cervical chain, which is right by your interjugular, as well as your supraclavicular. Don't feel any lymph nodes. You usually won't feel any lymph nodes unless they're swollen or have some kind of infection. But if you were to feel a lymph node, you would want them to be soft and kind of movable, not hard. Okay? So I'm going to have you sit back and I'm going to check for your jugular vein distension. The bed's at 45 degrees. So I'm going to have you turn your head. Okay? And then we'll go this side. Okay, and with you laying down, I'm going to go ahead and auscultate your carotid arteries for any bruits. you go ahead and have a seat up, we're going to move on to your posterior chest. Okay, we're going to start by inspection of the posterior chest. So you're going to look, make sure that they're not, having any shortness of breath or, not expanding. Upon doing that, you can also check for expansion of the diaphragm. You're going to have them put your thumbs at about the 10th rib, have them take a deep breath in. One more time. And you just want to make sure that your thumbs expand the same amount symmetrically. You can also check for diaphragmatic excursion while you're doing that. So what I want you to do is blow out all of your air. Okay, and you can let it out. Take a deep breath. And then I want you to take a deep breath and hold it in. There should be about 3 to 5, you can breathe normally. Should be about 3 to 5 centimeters in between those two areas from when the diaphragm expands. We're going to move on to palpate, and this is where you can check for tactile fremitus. So I'm going to have you work down the back and have you say 99 in 10 different spaces on the back and then 4 laterally. So when you're ready, say 99.
99. 99. 99. 99. 99. 99. 99. 99. 99. 99. 99. 99. 99. 99.
Okay, check the lateral.
99. 99. 99. 99.
Okay, thank you. So it's not uncommon to have a little more pronounced 99 in the scapular and second intercostal space area, and that's just because of the bifurcation of the bronchus. Also going to percuss the breath sounds on the back. The sound should be pretty resonant unless you're over any organs, which will create a dull sound. Okay, I'm going to go ahead and now auscultate the breath sounds, and as I said, there's going to be 10 on the back and then 4 on each side. So, deep breath for me. And then laterally, a couple more deep breaths for me. All right, sounds clear. All right, so we're now going to move on to the anterior chest. When listening to the breath sounds, you want to listen for any adventitious breath sounds like wheezing or rhonchi, crackles. He was clear. You can also sound diminished in the bases sometimes. But so we're going to go ahead and move on to the anterior chest. And just with like the posterior chest, we're going to start with inspection. So we're going to look at the anterior chest for any shortness of breath. Also going to look for any retractions in between the ribs, any heaving, pulsation, anything like that. I'm going to go ahead and then start. After inspection, I'm going to go ahead and go on to palpation. So just like we did on the back, we're going to do 8 spots on the front for tactile fremitus. So again, I want you to say 99.
99. 99. 99, 99, 99, 99, 99, 99, 99, 99.
Okay. We're then going to go ahead and you can also check for the apical impulse, which should be about the 5th intercostal space, mid-clavicular line. Right there. Okay. And we're then going to go ahead and go on to percussion. So just like the back, the front sounds should be resonant unless you're over an organ, which you really shouldn't be except for the heart. So can also find the borders of the heart. Can work in laterally this way. Areas of dullness compared to okay. Then gonna move on to the auscultation part. There's gonna be 8 spots on the front. We're also going to listen to the different heart sounds. So we have the aortic, which is the 2nd intercostal space, right sternal border, and then we have pulmonic or Erb's point, which is the 3rd intercostal space, left sternal border. We then have the tricuspid, which is the 4th intercostal space, left sternal border, and then the mitral, which is the 5th intercostal space, mid-clavicular line. While doing that, you can also assess their heart rate. You know, and you can also hear any murmurs in those certain areas. You can also tell if their heart rate's tachy or regular, irregular. Your heart rate was normal. A little fast. Are you nervous?
It's the light coat.
Oh, okay. Okay, we are now going to move on. Actually, before we leave the chest, we're going to go ahead and palpate the lymph nodes in the chest. So we're going to do the infraclavicular into the axillary area. And just like the lymph nodes within the neck, you just want them to be soft if you do feel any into the axillary area. You ticklish?
A little bit.
No. I'm just kidding. Okay, we're going to go ahead and lay back. We're going to go on to the abdominal portion of the exam. I'm going to put your head down just a little bit since we're not checking your jugular vein distension anymore.
It's such a comfortable bed.
Is it really? Oh. Okay. With the abdomen, you do things in a little bit different order. You inspect the abdomen, and then you auscultate, then palpate, and then percuss. So we're going to start by inspection of the abdomen. You just want to look at the contour of the abdomen. Is it round? Is it flat? Is it sunken? Any obvious masses sticking out. We're then going to go ahead and auscultate the abdomen. Listening to all 4 quadrants for bowel sounds. And in order to say that vowel sounds are absent, you have to listen for a full 5 minutes, which his are not. You're also going to auscultate the abdominal aorta as well as the renal, iliac, and you can go on to the femoral as well, which we're going to defer. So abdominal aorta. Then onto the femoral. Everything sounds great. So we're going to go ahead and go on to the palpation part of the assessment. So with light palpation, you just kind of want to use circular movements, feeling for any masses. And I don't feel any. I'm going to move to the other side. Can actually percuss for the liver. So you starting at the third intercostal space, take a deep breath in for me and out. And you kind of work your way. The liver should be about the fifth intercostal space. Work your way down until you no longer hear the dullness and rather the tympani that's associated with the abdomen, and it should be about 6 to 12 centimeters. You can also percuss for the spleen, so kind of working from the mid-axillary line, about the 6th to 9th rib should be the spleen. Again, working for dullness. We're then going to go ahead and you can actually palpate the liver. So what I'm going to have you do is take a deep breath in and breathe out. You're going to put your hand under the flank and just kind of feel for the liver. And again, you really shouldn't be able to feel the liver unless there's some kind of pathological process that's going on, and I didn't feel your liver. You can actually do the same thing with the spleen. So take some deep breaths in and out. And again, you shouldn't feel the spleen unless you've got some kind of infectious property going on, which I didn't feel. Okay, we're then going to move on, and you can actually palpate for the kidneys. So again, standing on the right side, you want to put your left hand behind your flank and have them again take a deep breath in and out and see if you can kind of catch the liver. The left is going to be less hard to palpate than the right will be. Same thing on the other side. Okay. Alright, I'm going to have you go ahead and sit up on the side of the bed again. I'm going to actually check for some kidney tenderness. So kind of with your fist, you're going to hit the costovertebral angle and just check for any tenderness that can be associated with pyelonephritis, kidney stones. Any tenderness there, just kind of on their flank. Okay.
No.
Alright, moving right along. We're now going to go on and I'm going to examine his extremities. So we're going to look at the arms for color, any duskiness, extremities, are they blue or dusky? Look at the fingernails for any clubbing, ridges. Then going to check your radial and brachial pulses. And there, 2+. I'm going to have you go ahead and pull to me and push me away. Okay. Hold your arms out in front of you. Okay. Keep me from pushing your arms down. Okay. And then going to move on to the feet. And kind of the same thing. I'm going to look at color at the extremities, make sure there's no signs of any venous insufficiency like color changes, brownness usually. I'm going to check your, posterior tibialis and dorsalis pedis pulses. Which are also 2+. Okay, can you lift this leg up for me? Keep me from pushing your arm. Okay, and then again with this one. Okay, wiggle your toes for me. And while I'm down here, I'm actually going to check his patellar and Achilles tendon pulse reflexes. So with them hanging.
Really got it. Sorry.
Okay. And then I'm going to kind of support his, no, you can hang it. And then check his Achilles tendon. And on the side. Okay. And then we're also going to check brachial reflex. Okay. I'm going to move on to the final, which is the cranial nerves. So the first cranial nerve is olfactory. That's smell. We're going to defer that. The second is optic. We've already done that when we did the Snellen chart, which checked your far vision, and then read the newspaper, which was your near vision. The oculomotor, trochlear, and abductance would be your cardinal fields of gaze, which we already did, which was intact. And that's also just keeping your eyes open and closing and that kind of thing. The trigeminal nerve would be checking for any twitches or facial atrophy, which I didn't note with him, and also your corneal reflex. The facial nerve, we did all that with the facial when you smiled and clenched your teeth, and all of that was intact. The acoustic is the next, and that was the Weber and the Renna, the whisper test, which we did. The glosseopharyngeal would be the gag reflex, which we know is intact, and then the swallow. Again, the vagus is also the gag, which was the next cranial nerve. The spinal accessory would be turning your head from side to side. Okay, shrugging your shoulders against resistance. Okay, turn your head against my hand. Okay, okay. And then the next thing would be the hypoglossal, which would be pushing your tongue in and out, and also pushing it up against the side of your cheek against resistance. And all of those are intact. The next thing, the very last thing, is checking your cervical and lumbar. So I'm going to go ahead and first of all inspect the cervical area. Turn your head side to side. I know you just did that. I just kind of want to watch. And again, at the other side, put it forward and backwards. And okay. Making sure that it's midline, moves okay, no pain on that. You can also kind of percuss and palpate and just make sure there's no tenderness upon those spinal processes. So we're going to go ahead and also look at the lumbar spine. Make sure that it's straight. You can also kind of palpate and percuss over those processes along the spine and make sure there's no tenderness. I'm also going to have you kind of stand up and twist from side to side. Okay, and then kind of lean like this from side to side. Any popping or pain upon doing that?
Nope.
And I don't notice any range of motion. So range of motion difficulty. So I would say that your neural system is intact. And your assessment is completely benign. So you're a healthy 30-year-old male.
Whoop, whoop.
And this concludes my assessment video for Nursing 620. Thank you.